Hello, good evening to you wherever you're joining us from. Good morning in some cases because you might be watching us from different parts of the world, or you may be watching a rebroadcast of the show. Welcome to your favorite show, Ask Dr. Saw. We trust that you've been having a fabulous and a wonderful 2025 so far, a healthy 2025 so far. Tonight, as usual, we are going to be covering a topic that is so almost every single human being that I know would have suffered from. That is headaches. And tonight, no one else to tell us about headaches but Dr. Saw. Dr. Saw is still in England, and he's joining us via Zoom. Dr. Saw, welcome to the show.
Thank you, Kash, and your team. And yeah, I'm happy to be here.
Yeah. How has it been so far? You know, what's the progress? What's the progress with young Dr. Saw's exams coming up soon?
She's prepared at the moment. Her exams are, in February, mid-February, around mid to end February.
Right,
so, yeah,
right.
She's doing her best, I would imagine.
Wonderful. We wish her well, and we wish her all the best.
Thank you so much.
All right, good. Yeah. So, Doc, tonight we're talking about headaches, and headache seems to be, there are so many different types of headaches, that we're going to be talking about. So, I'm sure our viewers, good evening to your viewers. We love having your input. We love your conversation with us. We love the interactiveness and you sending your questions. Just to let you know that we are going to be taking your questions from tonight's topic, whatever questions you're sending, and tomorrow, next week, we are going to be answering those questions. As you know, the format of the show, as it is now, is that for the first half an hour we deal with the subject, and then for the next half an hour we'll be dealing with your questions. So, headaches, Doc. As I said, there are so many different things I want to ask you about headaches. But let's start with the basic thing here. What is a headache? What is headache?
So, as you rightly said, Akash, there are different manifestations, and for different people, they can interpret headache differently as well, because you can have what we call radiating types of pain. So you may have a pain from the air that radiates along the air, and it may be deemed, patients may report it as a headache. And of course, that itself can cause headache, but we can report it as headache. But the real definition of proper primary headache is actually a feeling of pain within the skull.
Right.
So we'd say that. And
I'm happy you say the primary headache, because there are two major types of headaches, which is primary headache and secondary headache, right?
Absolutely.
Right. So Doc, I would want you to go. I mean, in as short time as possible, go through the various types of headaches and what It seems as if when I was doing my research on this, it says that about 80% of headaches are primary headaches. So what?
Okay. So the thing is, if you look at headache generally, it's a very vast field.
Yes.
And so understand every aspect of headache is difficult. And of course, yes, specialists in the field may elaborate in detail of different types of headache. But as a generalist, you want to be able to differentiate the worrying ones from the not so worrying ones. But when we categorize headache, or we classify headache as primary headache and secondary headache. So primary headache is telling us that this headache is caused from sensitivity of pain receptors in the brain. And also, a lot of times we don't know exactly the mechanism as to, or the etiology as to why you get these primary headaches. But we know that inherently it originated from some pain-sensitive areas within the brain. And it can manifest in what we call in a neurovascular way, where the pathology lies within chemicals, and it alters the neurotransmission, and it alters the blood vessels. So we classify it as a kind of neurovascular process that is happening in the brain. But that is getting too technical in terms of, But so the primary headache telling us that the headache is a headache disorder on its own. Whereas the secondary headache is headache as a result of another condition.
Mm-hmm.
Now, there are over 100 types of headaches.
Wow.
Think of that. Over 100 different types of headache that can be categorized in different ways as to the etiology, in terms of where in the body it's happening, as to the causes, as to other factors associated with it, and it's many. But primary confined to just not so many, secondary a long list. Because you know for a fact that almost anything can cause headache, and most of us experience these things. If somebody shout at you or speak too loud, you can say, hey, I'm having a headache.
Right.
If the light is too bright, you can say, I'm having it. And I'm not talking about a primary migraine. I'm talking about annoying things that can give you a headache.
Yes.
So think about somebody is annoying and they give you a headache, much less all the other serious things like a toothache, pains in the eye, pains in the whatever. It can cause headache.
Landlord call rent due headache. It happens, right? This is the practical things, yeah.
Absolutely. But as a doctor, our patients would come in with headache all the time, and they will tell us, and most of us, the patients, would know when it is a serious headache or not. If you get a trivial headache, lasts for a couple hours, and it's mild, no other associated symptoms, you may say, okay, let me take some painkiller and see how it goes. But if this headache is coming on frequently, and you can't pinpoint something, or you can pinpoint, but it's a recurrent nature, then you can say, hey, I think I have a problem. So the story about your headache is so important, and I want to emphasize this point, because sometimes when patient go to doctor, our job is to listen to the story, and the story gives it away. The story is 90% of what? If you describe your headache in detail, without even doing any tests, I can tell you this headache is more than likely, this is the cause, and this is how you manage it, without even doing anything else. And I would really want patients to understand this clearly, because sometimes, and I see this over time, practicing for many years, some patients come with very blurred history, and may rightly so that they can't differentiate some things in the way doctors would differentiate it. But try your best to try to have a clear description of your headache. So let us start with the primary headaches, and then I'll go through the secondary headaches, but I will just highlight, when I say primary and I say it's coming from within the brain and neurochemical factors into the brain. So the common primary headaches, so if there are 100 different types of headache, I can't go through them all.
Yeah.
So break them up into common ones, and then we will go through primary and secondary. So the common primary headaches would be, the most common is tension type headache. And you've heard of tension type headache at some point, when people say, I'm stressed.
Right.
I've got a headache, I'm stressed. But there is actually a headache called tension type headache. Mm-hmm. It's the name as in a primary headache disorder. So if a patient comes in and they say, okay, describe your headache for me. The classical description of a tension headache would be, it's mild to moderate type of headache. It's on both sides of the head. They describe it as a constricting type of a headache. So it's like a pressure or a constriction. So classical patient would come and say, it's like a band around my head.
Right.
So given those descriptions, and it may be associated with spasm of the neck, muscle pain, and usually, because you got to differentiate that from the, let's say migraine headache, we'll come to that in a minute, but usually tension headache would not manifest with all the other symptoms, like head movement doesn't really bother it so much, whereas in migraine headache, head movement will aggravate it. And it usually can last for about minutes, so let's say about 30 minutes to days. And that's your tension headache. And usually, most patients will complain of tension headache worse at the end of the day. So this is a patient, classically would be, come home in the afternoon, I'm stressed, my neck is spasm, my shoulder is tight, there's like a band around my head. I feel pressure. I feel constriction. And finally, it doesn't affect my so much of head movement. And there are some risk factors. Usually patients are stressed, or they're going through some sort of muscular spasm they get in their body as well, and that is what we call tension headache. And there's a special way we will manage it. So usually tension headache tend to be you can have chronic tension headache over time, but you would have that bout that just goes after whatever the cause is. You relax, less stress. We will give acute management. So your acute management would be pain relief. And the classic pain relief we start with. So pain management is usually like a ladder. I spoke about this before. You start with simple painkillers and then you go higher. But generally most tension headache will be relieved by your paracetamol and your ibuprofen type of family. So naproxen, ibuprofen, they are those type of family. There are patients who get recurrent tension headache, and we would then use a drug called amitriptyline. Tryptyline is an old antidepressant, but is no longer used so much for depression because there are newer drugs. It is used usually as a prevention.
Okay.
I know your next question would be, what are some of the alternatives? Alternative therapy.
Well, not really, not so much as that yet, because I'm hearing you talking about all the different type of headaches, and I'm thinking, how do I know what type of headache because how do I differentiate, or how can I pinpoint? Well, you know what? Based on my symptoms and based on how these things are hurting, this is what it may be. You talk about the band, feeling that band around your head for tension.
So that is why I say that the description is so important.
Right.
So if you come in as a patient and you say, Doc, I'm getting a headache, and I start to ask you a little bit about this headache. Okay, tell me about this headache. And you said, okay, this headache is all, feel in my brain. It feels tight. Everything feels there's a pressure. My muscle is tense. It's on both sides of my head. And you tell me the description I just described, I will then diagnose tension headache. But if you come to me and you say, I've got a headache and my arm is weak, or I can't see in one eye, or I get a headache and I've got toothache with it,
right?
I may want to say that is probably what we call secondary headache. So we're looking at now primary headache. So you don't have any other symptom associated with it. This is only headache. Right. You're not vomiting, you don't have diarrhea, you don't have fever. This is just headache. You just got a headache that's been going on for the past couple of days, and it's all associated with that description I give you.
Right.
Now, the second common primary headache is migraine headache. Now, migraine headache, as you know classically, so I'll say, okay, describe your headache for me. You say it's a headache that is one-sided. So usually it's unilateral, we say, one-sided headache. It's worsened with light and noise. So patients will tell you classically, I need to go into a dark room.
Right.
The light makes it worse. If the noise makes it worse, I want to be quiet in a dark room. It may be associated with nausea and vomiting.
Right, exactly.
Now, these are classic. That's your classic feature of migraine. So I'm giving you a migraine history. So I come classically and tell you this is the story, or I come classically and tell you this is the story of both sides hurting and is a restrictive band, whereas the migraine headache would be a pulsating type of headache. I feel it's throbbing.
Yes.
It's like beating it's pulsating in your head, and it's one-sided. So if it's one-sided, it's pulsating, it's with light and noise, and I feel sick with it, I can almost say because it's your classic migraine. Now, next week, as a follow-on on this, migraine is a very big topic. I want to go, and it's a very common condition that lots of people suffer with. I want to go on and talk about migraine. So we can say now, let us talk about migraine next week's topic. Right,
because I had so many questions as you were talking. I had so many questions to ask about migraine. So yes, we'll leave that for a separate topic by itself.
That is correct, because migraine is so huge that there are so many different new things coming out for it, preventative drugs and all of that. If I were to spend time going on migraine, then we wouldn't get time to cover. Today's topic actually is a general description of it. So people understand when to worry, when not to worry, what's a likely kind of headache I have here. And then when we zoom into, okay, you've got migraine now, then we will say, fine, these are the things we would look out for. So if you say your headache is one-sided, pulsating, worsened with light and noise, vomiting, associated nausea or vomiting, that's your migraine. And then there's another primary headache we call cluster headache. Now, cluster headache is where you have clusters of headache. They come in bouts of headache, and they can last from, you can have about 8 headaches per day,
Wow.
or you can have every other day you have a headache. So, and these bouts can last from minutes to hours. So that's your cluster. Now, the thing about cluster headache, lots of people sometimes confuse cluster headache with migraine headache. But they say, I was going to read something, but I don't think I have the time, a very descriptive way of one of the Oxford Handbook of Clinical Medicine. I remember studying that book in my, undergraduate. And it has a very well described part on cluster headache, where this patient is saying that there was no other pain in the world as bad as that. They were banging their head on the floor, and it's associated. So the classic cluster headache would be your one-sided headache that, as I said, can last. You can have it many times a day to about every other day. And so you have a bout that can last for several weeks, and usually one-sided, and it's always associated with eye symptoms.
Mm-hmm.
So you would have watery eyes, conjunctivitis type of redness in the eye, watery eyes. You may have runny nose. You have nasal congestion. You are agitated. You pacing up and down. You're going to and fro, because they say it's the worst headache or the worst pain you could ever experience.
Yes, yes.
And that is your cluster headache. Of course, so if you have that description, I would diagnose cluster headache. Now, the treatment is also different from your normal headache.
Mm-hmm.
I mean, your oxygen, we give patients oxygen when they have a cluster of those headaches. So think about you coming in with a headache like that. Normal painkiller not going to cut it. And as a matter of fact, we don't really give you oral tablets because it's so severe. Oral tablet is going to take 15 minutes to half an hour to work.
Right.
I want things to work right away on you. So we give injectables.
Mm-hmm.
And the injectable drugs, they're called triptans. They're the same type of drug that we use for migraine headache in the form of tablets. We give the injection form to cluster headaches. And also, so we give oxygen, so you give oxygen mask, and you give the triptans, injectable or you nasal spray. So you can spray the medication in the nose and it's absorbed faster. And that's
okay.
And to prevent it, if you get enough of clusters, we give a drug called verapamil. And it's a blood pressure tablet. So
okay.
Usually these are preventive drugs. So we've got migraine, we've got cluster headache, and we've got tension headache. Those are your common types of primary headache, meaning that these headaches originate from something going on in the brain. I mean, there are other types of headache in the primary category. You could have, they don't describe, they put them in other category because there are lots of overlapping into those types of headache. And then you have where the trigeminal nerve type of headache. Now, if we go on, so these are the 3 common ones to remember, however, is your cluster, your migraine, and your tension.
Right.
Those are your classical primary headache. Now, the secondary headache, as I define, would be secondary to something else. So let us start with what are the secondary types of headache, or what could be something else. What are we worried about generally in headache if you come with a headache, a patient comes with a headache? We are worried about, do I have tumor of the brain, or do I have a bleed in the brain? That's the first thing patients would come with. If you get a headache, what do you worry about?
Yeah, something going on in your head. Something's going on in here, yeah.
Right, and if I know that, okay, is the worrying thing always at the back of our mind, we think in the worst.
That's right, yeah.
So you're thinking that, is there a blood vessel that's burst in my head?
Mm-hmm.
Or that's like a stroke? or do I have a tumor? So the thing is, we can then look at secondary headache as cancer of the brain. I'll come to that because that's an important one, what we would look for if we suspect cancer of the brain. Bleeding in the brain, so patients who have a burst blood vessel. So there are different types of bleeding in the brain. Now, the classic bleeding in the brain that we know is stroke, right?
Right.
There are two types of stroke. There's a stroke where a blood vessel bursts, and that's called hemorrhagic stroke. And there's another type of stroke where there's a blockage of the blood vessel. Like when you get a heart attack, you have a blockage of the blood flow to the heart.
Right.
You get a blockage of the blood vessel in the brain. And so those are the two types of stroke. But there's another type of stroke, which is called a subarachnoid hemorrhage. And this is the type of stroke you get in young people. And they have a malformation where a blood vessel is a little bit weakened, like an aneurysm in the brain.
Yeah.
So this is not your classic stroke where you have high blood pressure, you're smoking, you have diabetes, and over time, your blood vessel damage and you have a stroke. These are patients who genetically, or they're sometimes born like that, where there's weakness in the wall of the blood vessel. So these strokes happen in young people. And it is called subarachnoid hemorrhage. You know Sharon Stone, the famous
actress, yes.
Famous actress. She had one of that subarachnoid hemorrhage.
Okay.
She had a stroke at a young age. And that is your subarachnoid hemorrhage. And it's good to pick up. Now, that can present as a headache in the first instance.
Okay.
So patients and the description, and this is very important. So I would go through something where, when do I worry if this headache is a concern or not? We are worried in certain cases. So we talk about a stroke, we talk about bleeding. The another cause of secondary headache would be infection. So you're worried if you have meningitis.
Meningitis, yes.
Encephalitis, that is the lining of the brain, the inside of the brain is infected, or meningitis is the meninges, is the surrounding of the brain is infected. You know, you heard of meningitis.
Yes.
Right, but in those patients, they will come with fever, they would have neck stiffness, the light will be too bright, they'll be lethargic, they may have a seizure, they'll be semi-conscious. That's your meningitis classic. And you know that's a secondary headache.
Yeah.
So you can have a neck problem where you have arthritis of your neck and you have headache as a result of that. You can have sinus. So lots of time, patients have sinus problems. So if we start with anyway from the head coming down, you can have glaucoma. So glaucoma, where there's pressure in the eye, that can give rise to a headache. Coming to the nose, sinusitis. These headaches in sinus headache, you have nasal congestion, your nose is blocked. When you bend your head down, you feel the headache is worse. You feel your head is full and congested. You know what we say, head cold?
Right. Head cold, yes.
That's your sinus problem. And that can cause headache. That's your sinus headache. You can have, there's something called temporal arthritis. So there's a blood vessel that runs along here, and you can have inflammation of the blood vessel. And that can give rise to headache. Now, so if I press in here and you're having pain and you're having headache, this is a serious condition as well, because if there's inflammation of the blood vessel, you can have a blockage of the eye. It can go to the eye, into the blood vessel of the eye, and cause blindness. So these are secondary causes of a headache. Now, I don't want patients to think, okay, every headache I'm going to be worried and thinking is going to kill me. As I said to you, you know the type of headache. But there are some features I want to talk about that you should be cognizant of, or you should be aware of. So one, there are a couple of things we look for. If you have headache, which comes on with, let's say you have fever, you're really unwell, and you have a headache, I would want you to see the doctor to make sure you don't have meningitis. But I would expect you to have a temperature, I'd expect you may have a rash or not, and you may have the light is too bright, neck stiffness, you can't do this, it's painful, so that's your headache. But importantly, if you have headache that is associated with what we call neurological signs, remember this word?
Yes.
Neurological signs. What it is, so we would say stroke-like symptoms for the layman.
Right.
we would call this stroke-like symptoms. So what is stroke? How do we know you're getting a stroke? If you come and say you're having a headache alone, I would say, fine, could be anything. I wouldn't think of stroke. But if you say you have headache and your arm is weak, or your face is twisted, or your speech is slur, or you can't see in one eye, those are called neurological signs. And it could be as a result of a blood vessel burst or blocked, that's a stroke. It could be as a result of brain tumor. So we call that neurological signs. So any headache with neurological sign, you should see the doctor right away and have a scan of your brain.
Right.
That is very important.
Yeah, Doc, what are some of the tests that can be done to determine? I mean, you said that when patients come and they present themselves to you and they tell you the little history of their headaches, most of the times, if not all of the time, you'll be able to pinpoint exactly what type of headache they have. But in other cases, what are some tests that can be done to determine the types of headache?
Right, so
medical tests.
Primary headache is more a diagnosis of exclusion.
Mm-hmm.
Because most people come in with a headache, it's chronic, it's there all the time, and the story tells you the type of headache. And
right.
What we do a scan for is, the scan doesn't tell us this is migraine, this is cluster, or this is tension headache. The scan rule out other causes and other important secondary causes.
Okay.
So a brain scan can either be a CT scan or it can be an MRI.
Right.
A CT scan consists of radiation. So we don't want to do many CTs. We do CT in emergency situation. So you come in with a sudden headache and I really want to know what's going on. It's easier to organize or get a CT done. An MRI takes longer. You have to go into that tunnel and sometimes it's not convenient. However, if you have chronic headache that have been having headache for a week or 2 weeks or 3 weeks, then I would organize an MRI for you because you can wait and we can pre-plan the MRI. Whereas if you come in with a sudden onset of a headache, I can then arrange a CT scan right away and you have that headache. I want to just say, so the point what I'm trying to make quickly now, the time is...
We have 10 minutes. We have 10 minutes. We have 10 minutes.
10 minutes.
Yeah.
So I want to say some of the red flags. So when you're seeing your doctor about a headache, you want to make sure that you don't have any of the red flags to suggest. So our job is usually to find out if the patient has got a red flag, to say this headache is more than just a normal headache, which we can wait to treat. So we want to make sure it's not a brain tumor. We want to make sure it's not bleeding in the brain like a stroke-related condition or something called a subarachnoid hemorrhage. And we want to make sure it's not an infection. And we want to, so all these things I talk about, a stroke, you will have other neurological signs. Brain tumor, you would also may have neurological signs. And how do we know what is neurological sign? I say you get weakness in the muscles. You may have sensory problem, whereas you can't feel on one side of the body, one side of the face. So you get limb weakness, sensory feeling problem. One eye, you might not see properly on the one eye. Or when you look at the pupils are different. You know, the size of your pupil
right.
look different. That's a neurological sign. If I tell you, when you go to the doctor, something they tell you, touch my finger and touch your nose. You know,
right.
Like
Yes.
If you don't lose that coordination, that's a neurological sign. So if I tell you do that and you can't do that, I'm worried. If I tell you to stand straight and close your eye and you fall over, that's a neurological sign. If I tell you to walk, you know, when you're drunk, we tell patients, can you walk heel to toe?
Yeah.
You put your toe by your heel and you move one step after. If you can't do that, that is a neurological sign. So any headache with neurological sign, straight to the doctor. Any headache with fever that is a little bit more than just a flu or a cough and cold, because any cough and cold can also give you a headache. But if you have the meningitis type of, where you have fever, cough, cold, rash, and neck stiffness, doctor, that's an emergency. Now there is the other thing you look out for. You heard of thunderclap headache?
Right, thunderclap headache. I was to ask you about that, Doc. Thunderclap headache.
So a thunderclap headache, the definition really is a sudden onset of headache that reaches its maximum intensity within a minute.
Wow.
And it is described, I mean, when you look at thunderclap headache, is one of it, you have to. So if you get a headache like that, you should always see a doctor. Because you risk having a bleeding in the brain. So we talk about subarachnoid hemorrhage, like what that actress had, Sharon Stone. Thunderclap headache is a presentation in half the cases. So patients, the common is they have a sudden headache, and the classical description they will say, as if someone take a baseball bat and hit me in the back of my head.
Wow.
So it's a sudden onset of headache, reaches maximum intensity within a minute. That's your thunderclap. But of course, there are other causes of thunderclap headache, where you can have what we call constriction of the blood vessels and all of that. And there's another headache you can get during orgasm. So you can have coitus cephalgia, they call it, where you have headache during or just around, just after orgasm. So that's your sudden headache as well. But of course, you know, you would have that as a history, and then you can find this is a benign condition, it's innocent, it's not going to do you any harm. But if you have a sudden onset of a headache that is as a thunderclap headache, you should see the doctor to ensure it's not, a bleed in the brain.
Yeah.
And that's your summary of headaches, really.
Yeah. Doc, when there are so many psychological effects to a headache also, because I know people say, you know, with migraine, they said, man, look, I feel like killing myself because I can't deal with this anymore. But when is a headache dangerous?
Well, it's dangerous when you have all these. If you have neurological sign with a headache, I would say, or fever, those are the two dangerous ones. In terms of, for me to say right away is dangerous. If I do a scan and I feel that there is nothing going on, and there is also conditions where you have inflammation of the blood vessel, if I've excluded all of that, we'll say it's not dangerous. But if you have any of those conditions, then I would consider it dangerous. So if I do a scan and there is bleeding in the brain and there is, a tumor, so that's a dangerous headache. Of course, you need to deal with that. So the headache is really dangerous when you have neurological signs or signs of infection or signs of inflammation in the body. Yeah. So if you have those associated headache. So I wouldn't say so the psychological component you talked about, that can make it dangerous as well in terms of patients get depressed, suicidal, and they give up the will to live.
Right.
I mean, I would consider that dangerous. But the point is, a migraine headache not going to kill you. A tension headache is not going to kill you. A cluster headache is not going to kill you. They are severe, disabling headache. You may not be able to function your day-to-day activities, but the headache itself not going to kill you. So I wouldn't say, this is a medical emergency. Yes, I want to treat it because the severity is an emergency. So you'll treat it in that way, but not that the headache itself, I need to, like if you have a bleed in the brain, I need to urgently rush you as an emergency. I need to rush you for a brain tumor as an emergency. Those are the ones that I would be worried about. Or meningitis, because potentially every minute, every second, meningitis can kill you.
We just have under 4 minutes left for this segment. Treatment. Let's talk about treatment. And in that aspect, in that, let me add also to say, you can also talk about, I know you asked this earlier about alternative lifestyles and therapy and so on.
Sure. So,
but talk about treatment.
Your classic treatment would be your painkiller in terms of, we start with a pain ladder, your paracetamol is your normal painkiller, your ibuprofen family, they're called NSAIDs, a non-steroidal anti-inflammatory, and you can escalate. We try not to give too much strong painkillers because some people use codeine-based product, but we try to advise against codeine and even morphine-based product for headaches when they are really, really bad. But the treatment generally for your simple headache would be ibuprofen, aspirin, paracetamol. That's for your simple headache. Once we have a diagnosis of so we talk about primary headache, so your cluster headache, we talk about oxygen, we talk about your preventative drug, as in your verapamil. When you have migraine, I will come to that next week in terms of specific drugs for that. But when we talk about a secondary headache now, the treatment is based on the underlying cause. So I said secondary headache is from an underlying cause. So if you have a sinus problem, we try to treat that sinus problem. If you have meningitis, we will treat that meningitis. If you have a brain tumor, we'll treat that. If you have a stroke, we'll treat that. Toothache can cause headache. You can have a nerve problem, trigeminal neuralgia. We try to treat that. So your secondary headache, you treat the underlying cause. Your primary headache, you start with simple painkillers, and then you add on based on the specific type of primary headache that you have.
Okay.
And the alternative, quickly in 5 seconds, an alternative treatment. So we want to de-stress you. As I say, your primary headache, tension headache, you want to do stress relief therapy, whatever it is, massage, aromatherapy. That's these are all good. Your acupuncture is very useful for headaches. Physiotherapy sometimes for your muscle spasm and some of the tension type of headache. And you want to cut down on your alcohol. You want to exercise. I mean, sedentary lifestyle promotes headache. So the more you're relaxed, the less stress you have. Eat healthy, lots of fluid. Dehydration can cause headache. So you want to drink enough water, cut down on your alcohol, lots of fruits and vegetables, go for exercise, socialize, interact with people.
Right.
Lift the mood.
Yes.
Those are all your non.
Yeah. Doc, on a lighter note, one last thing to closing off here in terms of headache. How do you treat the headache when you say, by that lady when we got there, or that husband we got there is bare headache? How do we deal with that?
Holy shit, you want to get me in trouble now.
All right, I know we got some viewers out there who are always sending in always contributing. But I'm just on a lighter note, just.
I know, of course. I mean, the thing is, we say it all the time. Oh, this girl gives me headache.
Yeah.
Woman gives me headache, or this man gives me headache. But in a relationship, sometimes those are just banter. But if it is a genuine concern where my partner is giving me headache, so much so, that means he or she is aggravating me. And I need to take that on board and have that conversation. Since we're having a conversation, whatever you're doing is annoying, and maybe we need to look at our relationship. We need to have some therapy, some counseling. Look how we can rekindle things and let you don't be so annoying.
Ease the headache in the home. Hi, good evening and welcome back. We are now going to be dealing with the second segment of the show. And we are going to be dealing with your questions from last week, actually. Last week we dealt with UTIs, and many questions came in through our chats. And we really appreciate you, the viewers, sending in your questions. It doesn't have to be about the topic. Tonight we're dealing with headaches, but it doesn't have to be about the topic. You can send in your questions about anything. So, Doc, I got some questions here for you. The first one is, Doc, women going through menopause are prone to UTIs.
Absolutely. And I remember saying that on the UTI topic that I did, that the cause or the etiology, we say, lots of time has to do with the bacteria that lives in the perineum. So we say urinary tract infection in female usually follow what we call an ascending, they move up the urinary tract, and they get infected from the vagina, the perineum area, so around the vagina area, and bacteria gets into, because the urethra is, the tube from the bladder outwards is short, and the bacteria gets in there. So it is very important that whatever bacteria in your vagina, we want that bacteria to be the healthy bacteria that your vagina is accustomed to. Now, during menopause, you have decreased estrogen, that is your female hormone, and it can change the makeup of your vaginal bacteria, because the vagina would get it will get drier, and it can get irritated, injured, so you get lots more bruises. You create different bacteria can form, can grow there, and those bacteria get into the urinary system. So the answer is that yes, during menopause, you're higher risk. Now, that is a condition so common, and it's so easy to treat, but lots of us don't even present to the doctor about it, or we are embarrassed to talk about it. And it is so easy without any complication. I've given patients treatment for it, and they're so thankful that they have transformed their lives. And the treatment generally would be topical estrogen. So the cream, like you take HRT, consists of two types of hormone, estrogen and progesterone, where you take orally, that is, by drinking it, Whereas in the vagina, we give cream, topical, like a gel or a cream, but it comes in a little tablet form that you put up the vagina. Now, that's your estrogen, topical estrogen. Now, the good thing about that, it doesn't get absorbed so much into the body to give you all the risk associated with estrogen. It works nicely locally. So you don't have to worry. Even patients with breast cancer, we give them topical estrogen. And that's a very good treatment, and I would encourage patients that talk to their doctor about that and get it, the cream. And so in the beginning, I use it every day for 2 weeks, and then 2 to 3 times a week thereafter. So it doesn't have to be every day, but just to restore the balance in the vagina.
Okay, great. So I'm gonna. There are 2 questions that I want to string together here that we have here. Doc, is Dettol good to wash your private parts regularly? Now, let me add this other question to that, because it's sort of tie into this. Doc, I heard that they got a soap, and she described the soap. I don't know if I can use this word on screen, but it's to wash. It's a special soap that is being advertised to wash the vagina, and a special soap to wash the penis.
You can use any word on screen.
Okay, so let me say it says, Doc, I heard that they got a patty cake soap and a body soap. I want to know about that soap. So these products has been advertised all over Facebook. I see Robert laughing in the control room, but it is being advertised a lot to say that, look, this is the best thing. And let me tell you what some of the benefits are said to be from these soaps. It tightens the vagina. It keeps it clean. It has a good scent and all these kind of things. So that is a question that came from one of our regular viewers also. So one person is asking about Dettol, if it's good to wash with Dettol regularly, and the other person is talking about this what they're calling patty cake soap and body soap.
Oh, so let's address both questions. So
right.
The Dettol element of it, I would say it's a no-no. Dettol is an antiseptic. As a matter of fact, this will tie into even the other question with the soap. So
right.
There isn't, at the moment, no medical advice that shows benefit in washing the vagina internally.
Okay.
So doctors should discourage the use of whatever it is to douche. Douching, they wash the vagina. And there are lots of things that are sold out there. So first of all, Dettol, if we address Dettol by itself, is a very strong antiseptic.
Yes.
It's got a pungent smell. I don't know.
It burns your skin.
Yeah, it burns you. You got to dilute it and all of that. So without a doubt, it would not be something. The vagina is more delicate than that.
Mm-hmm.
So I would not think at all Dettol is healthy to put there to start with. It can cause irritation, discomfort, God knows what else. But the answer to that is by no means Dettol. Now, people may say, okay, why don't I just put a little tinge? But what purpose does it serve?
Yeah.
You don't need to put a tinge of Dettol for anything. First of all, that little tinge is not going to make a difference in terms of if you want to create some antiseptic into the system. And also that's dangerous because I don't want to kill the bacteria in your vagina necessarily, unless it's harmful bacteria. Most of the bacteria that live there, they're beneficial to you. Mm-hmm. So I don't need to kill that. If I disrupt the whole mechanism and there's a condition where you have bacterial vaginosis, and I'll tell you about that, if you have an infection, then of course we will treat that and maybe we can create a different equilibrium where we use probiotic stuff. Mm-hmm. Probiotic, like where we use probiotic yogurt drink for the bowel, and it's got good bacteria. They also sometimes use the same type of probiotic in gel forms that you put up the vagina. That is patients who have recurrent infection. I wouldn't say you need to do that, but if you're having recurrent vaginal discharge, smelly vaginal discharge, which we call vaginosis, bacterial vaginosis, I then may say, fine, I've treated you 5-6 times this year for that condition. There seem to be some disequilibrium of your bacterial flora, that is the bacteria that grows in the vagina, and maybe we can rebalance it by using some probiotics, some good bacteria. But the intention is not to kill, use antiseptic to kill. So Dettol is out. Now the Pata soap and the body soap you're talking about, likewise, they will have something that the intention, what you were saying there, I need to wash the vagina. Well, the only guidelines that says that permit washing is external washing. There's no guideline tell us that we should regularly wash the inside of the vagina. So external washing, where you just use water and mild soap externally, you don't put it inside, you don't put your finger in there, you don't do anything in there, you just wash the outside of the vagina, that is healthy. But I would not recommend any of those Pata soap. Now the scented stuff as well, they're not advisable. I mean, yes, patients can use it and they're fine, but lots of the scented stuff can be an irritant.
Right.
So I would not want to do that. So yeah, I don't think there is any medical evidence to substantiate any of those claims, and it was not something that I would recommend unless there are specific bacteria that I'm trying to kill, then I'll treat with antibiotics. So if a patient comes in with recurrent vaginal infection, I will do a swab. So I'll take a sample of the vagina with a swab, I send it to the lab, we test that, we see what type of bacteria is that, and then I give the appropriate antibiotics. Sometimes you can treat blindly, okay, one off, let's see how this works. We give what we call a broad spectrum antibiotic that can cover lots of organisms, and that sometimes solves the problem.
Right. Doc, I think we dealt with this one. Can one have a UTI and a STD simultaneously?
Definitely. They can present alike. Some STD can present like urinary tract infection, where you have burning when you pass urine, you can have a discharge. The STD generally will give you more of a pussy discharge from the urethra. So, but you can have them together. There's nothing stopping you.
Okay, Doc, why milk is not allowed when using meds for UTI?
Well, that is not true in totality. That is true to an extent. So, in urinary tract infection, there are some antibiotics that are... So the idea of milk, generally, against antibiotic is that it decreases the absorption of the antibiotic. So you're taking an antibiotic, there's a milk in there that will change the absorption of the drug into your system.
Okay.
And that's the simple reason.
Okay.
So you get less concentration of the drug in your body. So some milk can even affect about 30% of the absorption of the tablet. Okay. So when I'm giving you a dose, it's like you've got 30% less of the dose.
Right.
Now, for you to kill bacteria in your body, you have to have, and we've worked this out, medically they have worked out what concentration of this drug need to be in your body to kill the bacteria in your body. So if milk is going to decrease absorption, then you don't want the drug with that. But by and large, some tablets, so depending on which tablet you're using, the regular ones, the stronger ones like the ciprofloxacin or flaxacin, forget the category. Remember, but drugs of that category, they can interact with the milk and you lose absorption of the drug. However, the common one that we use, trimethoprim, can be used, and that is used for UTI. Nitrofurantoin, macrobid, that can be used, and that's a common drug that is used. As a matter of fact, in the UK, I use nitrofurantoin, which is macrobid, as the first line, because there's lots of resistance with trimethoprim. So different country and different locality that you live, the guidelines for management of urinary tract infection, it has to do with the antibiotic resistance and the bulk that is prevalent in the community. So those trimethoprim, nitrofurantoin, milk doesn't affect it, whereas the other cefalexin and the ciprofloxacin, the quinolones, okay, that's the name I was trying to get. The family of the quinolones, it can affect it. So yes, it's just to do with absorption.
Okay, great. Does metformin damage the kidneys?
Answer is no.
Okay.
However, there's a caveat to this.
Yes.
So metformin by itself doesn't damage the kidney, and patients come. Even last week, a guy came in and he said, "Doc, my family in the U.S. told me that I can't use metformin; it will damage my kidney." I said, "Well, that's wrong. That's not true." And I had to show him the evidence. Now, it doesn't affect the kidney, but what tends to happen? Metformin can affect the metabolism in your body, right? And it produces. It can affect your body break down certain type of product. And it can increase your lactic acidosis. You know, we have different metabolic pathway cycles that give us energy. And metformin can cause your body to build up something called lactic acidosis. Lactic acid. So you get a high level of lactic acid, you get something called lactic acidosis. But that is if you have problems with your kidney already where the kidney is not excreting the product. So if your kidney is damaged already and it is not excreting this it's causing a buildup of it.
Right.
Or also the kidney is causing accumulation of your metformin because metformin is also excreted by the kidney. So if there's a buildup of this lactic acid,